and the one of the worries is whether the patient had initial first aid. Uh, Whenever thermal burn occurs, even for a chemical burn, we advise on immediate irrigation. That is irrigation with running room temperature water for 20 minutes. So if performing that will reduce the burn depth and the area by taking the latent heat off. So if it was a patient who was not properly managed, first aid not given, and maybe being given unorthodox treatment, I'm little worried about early chances of infection on this patient than a patient who's presenting freshly. So in this patient, because I have that worry, I I'll be little quick to start on a scrub down and probably go for a dressing, silver dressing, because it's very important. Hand is a very important organ, and the mobility functionality of the hand as well as the ESS is. So I will go for a scrub down, and if the facilities are available, I'll go for a silver impregnated dressings. But we know that those are costly also. So if the unit has access to silver impregnated dressings, then we prioritize on the hands and some of the areas. But if you don't have access, then it will be daily psilocyphodacin dressings. Again, as Dr. Selaganesh mentioned, the fingers have to be uh, dressed individually so that the patient can be mobile, and the patient is from day one uh, promoted to use the hand. Even at resting, we can put a splint, but at least 3 to 4 times, the patient should be taken off the splint to have maybe meals or individually mobilized. In this patient, probably I will start antibiotics. We can discuss antibiotics because we don't promote antibiotics for acute burns. We wait until the day 4 or day 5 for the possibility of infected burns. So this is this burn is on day 2, but because we are not sure about what happened during that time, I would think of starting antibiotics, analgesics, and zinc and vitamin C for this patient, and observe for a few days. If the epithelialization is occurring, then I would allow the epithelialization. I'm not majorly worried about the palm aspect, because palm aspect, even little bit of the healing by secondary intention, we still give a surface which is resistant to friction. But on the dorsum, if the burn is not healing within the first 10 to 14 days, then it's time uh, to plan for cover.
Yes, sir. Thank you, sir.
And at this stage, this probably the second photograph shows with this specificity, is it a little bit of infection and slough?
So a little bit of slough was there, and
Yeah,
no obvious evidence of infection.
yeah, because at that level, before the any significant infection sets in, this is a time to intervene to debride and go for tangential excision. That is a debridement of the burn tissues until punctate bleeding is available, and go for a skin graft. Palm aspect, we won't be grafting, we won't healing by secondary intention. But the dorsum, I think this is the time, because hand is not overtly swollen, and if the patient is not showing features of infection, then because if we lose this opportunity, then we'll have to wait until all the infections have subsided before doing a skin graft. What date, Oshan, is this?
So this is around day 4, sir.
Yeah. So this is the opportunity to do a graft, I think, rather than waiting, because then there'll be infection, pockets of pus.
Yes, sir. So as you mentioned, according to this appearance, we also decided on tangential excision, and we did the skin grafting. So this is the photo after skin grafting, and the graft has accepted well. As you highlighted, sir, to preserve the function of the hand when the burn depth is more than a superficial partial thickness burn, so we have to go for a graft. And as you highlighted, sir, the best opportunity or the window to do this intervention would be early if you decide if the burn is more. And as you said, we were able to manage without any infection and graft loss, and the patient had a good outcome after the surgery.
Was this
And
applied?
So
Sorry,
sorry.
did you all apply a silver dressing at the beginning, or what? What is the dressing you all?
So initially, because we didn't have silver dressing
Okay,
at that
okay.
point, so we didn't do silver dressing, sir. So Yasa sir wanted to ask a question.
Yeah, Oshan, can you explain why is this separation between the middle and the ring fingers, and why at the wrist there's a transverse cut? Why is this separation?
In terms of fingers, we separated because if we put it as a sheet graft, so because of there's a risk of the contraction, mainly the secondary contraction is more, and actually the in the dorsal palm, dorsal aspect of the hand, that middle line is because we couldn't apply a sheet graft at that point, so we managed to do the fingers separately. And I think there are different techniques to avoid these secondary contractions. Can you elaborate on that, sir?
No, actually, you have done the correct thing, because as per our Burns guru, Dr. Jahandini Perra, reiterated it's very important that you have to have this separation, because it's between two functional parts of the hand. So that separation, the little finger and the ring finger, it's a separately functioning part of the hand. So it's benefits when you do that separation on the dorsum. And at the wrist also, the wrist joint crease, probably even I prefer even if that transverse separation was even little distal to the than this in the wrist. This is points of interest.
As Dr. Yas told initially, this I think would have been saved without graft if we have had silver dressing. And other suspicion is whether they have applied any Ayurvedic or natural products before, because the day for infection like this is bit unusual. So I feel they might have applied some Ayurvedic or natural things before coming. So that might have provoked the infection.
Yeah. Shall we move on to the next case? I think that's a good discussion on this hand burn. So it could have, I think this is it's a decision-making thing. Remember, if the burn comes late, when you do the scrub, go for a culture ABST. So if it is streptococcus, never graft. Otherwise, you can graft. Most of the other bugs up to the colony count of 10 to the power 3, you should be able to graft. And even if there's evidence of bacteria, but if you think the If you think you can get a good clean surface, you can get a graft to take. Only contraindication is streptococcus. Never graft on streptococcus. You are going to lose the skin graft. That's the only message if you're trying to graft on a hand. So culture is important, and you can actually get a gram stain done next day even if something is growing, and they will say that it's a strep or not. So you will have an idea what is happening. Oshan, can we move to the next one?
Yes, sir, we can move to next one. So the second case is a 4-year-old child, female, accidental hot water burn, presented after 2 hours of the incident. And so this is the appearance. So I would like to invite Dr. Selva Ganesh to comment on this patient. Sir, can you comment on this patient?
This is very common scenario, especially in the cold time. They start a bit of runny nose and all. Then parents give some steam inhalation, and then they end up like this. And sometimes they pull the table cloth, and then the hot water gets poured on them. So this is very common scenario we see with kids. And here the kids looks around chest and the abdomen and the patchy areas on the groin as well as neck and the left hand. So we had to consider inhalation injury as well, because the area just in the upper chest and the neck has got burned. So we had to look into that matter. And then this looks superficial to mid-dermal. So most of the time I go for the initial within 24 hours I go for the scrubbing under general anesthesia and after initial fluid management. And then if the collagen is available, I apply collagen sheets for these children. And especially when we apply collagen sheets, we have to be a bit cautious, because when the collagen sheets gets dried up, it becomes basically very hard, and it won't allow movements like so chest expansion and abdominal breathing we have to consider. So we should cut the sheets into different sizes, and we have to allow there are gaps in between, maybe 1 centimeter gaps. So especially if the child has a patch on the cheek, then if you apply the sheet as a one sheet, she can't open the mouth next day. So we had to cut in pieces and apply. And it's a good dressing. And I have noticed when we apply collagen dressing, then they have very good pain relief. After recovery, they just play and they forget everything what happened. So I don't know, I can't explain why it happens, but I have noticed in kids after collagen dressing they do very well. And after I keep for over a day, and then their intake is good and inhalational injuries excluded, then they will go home the next day. But only advice we had to tell the mother or parents is not to wet this. If they go and wet this, then our collagen effect sheet, the effect goes away. Basically, it may come out, and that is not advisable. So usually when we apply the collagen sheet, I don't put any dressing on it also. So just clean cloth will be there. So with the kids, sometimes it's difficult because they will be running here and they are pouring things. So that's the parents should be very careful of it. And as this child has presented initially, so we had to do the fluid management. As you all know, there is a Parkland formula, but usually I don't advise my team to follow the Parkland formula. I just go by the urine output. So if this patient has around more than 15% of its burn surface area, so its catheterization also will be a good guide unless the child produces enough urine which from the history. So sometimes they may be pamper wearing kits. So we can, if we can roughly estimate the output, then that means if clinically they are not dehydrated, and then we can go for. Otherwise, better to have a catheter and measure the urine output. So usually 0.5 ml per kilogram per hour is my target. So if they can produce that much of urine with the boluses or whatever the oral intake, then it would be enough.
Okay, so thank you, sir.
Any inputs from Dr. Gahan?
I think Selva has outlined the management perfectly well. So if you don't have collagen, the Vaseline is also quite acceptable, and Vaseline is also used world over for this type of burns. There is some concerns over exudate. Even with collagen, you get some exudate. So perforated collagen may be better if you feel that child is bit the wound is oozy or weeping. Otherwise, the blister formation under the collagen is also there's a problem, and sometimes the collagen gets if there's a lot of exudate, the collagen gets what do you call waterlogged and probably displaced, or sometimes they even disappear. And the other important factor is if you're securing. If you're securing, you have to secure it very well. Kids are very notorious to take dressings out, and parents will have a time attending to dressings. But make sure that they don't wet it, because then the whole purpose of putting a dressing is lost. I think the catheterization decision has to be taken case by case. Don't catheterize these kids without having a real think about it. Think about it very seriously, because it's very difficult to do a catheterization. But you have to do it under GA. Don't do it. No, you don't have to do it later on. Then it's an early on decision. You can take the catheter out if you think the thing is settling very nicely. The issue with exudative ones, on top, even collagen, if it's exudative one, the dressing will get stuck onto the collagen. So that's taking it off in a child will be amazingly difficult. If the exudate becomes very thick and smelly, the parents are worried. So sometimes I will put a Vaseline layer on top of collagen also. If I think the exudate is heavy, especially big burns, and I think the rest of the thing is the same management. These are smaller practice points that I've learned over the years. And somebody has asked the nipple areola issue. The nipple areola is not a major concern. The biggest concern would be the color difference between the burnt areas and non-burnt areas, which will be the problem for parents, and that will have to be managed by a sort of a plastic surgeon, and you have to. There are few techniques to take the color back, but those are case by case, and the different types of applications have to be managed very carefully with the discussion of the occupational therapist, because some of the areas might have some. Sometimes they get smaller point areas. You get patchy hypertrophic scarring. So those are the things that I would like to add. Yasas, anything to add?
Yeah, yeah, Gan. For children, I try to cover the burns, like cover the collagen, because they try to pull, and if you pull from one edge, then eventually it starts coming off. So the best was during the tsunami time, there was a donation of like net dressing set on it, which was amazing for the chest and the arms. Everywhere you can secure dressings, but otherwise I will put about 2 or 3 layers of ghost towers and lightly wrap with uh, this cotton crepe bandage, allowing enough breathing space, and so that the child can't pull the dressing off. And usually we leave the dressing, collateral dressing, until about day 7, 8, or up to about 12 days. Usually by that time the epithelialization will occur and the dressing will most of the time fall. And so the risk of hypertrophy scar is minimal with using collagen dressings than using daily silver sulfadiazine, because we know silver sulfadiazine T half is 12 hours, so you have to go for daily dressings. There's no option of doing it day 2 or 3. So than that, if available, collagen is I think a better exercise for the child, and the even the expenses are concerned. And you get minimal hypertrophy scarring. Even the pigmentation improves with time, or you can use some special techniques as Gan mentioned. And the other thing to mention is what the Dr. Selvaganish mentioned about the steam inhalation. Please advise all the patients, if somebody wants to inhale steam, if they want to use a pot, ask them to keep the pot in a sink and then do any inhalation because it can't topple from there. But if they want to use steam inhalation otherwise, then it's better to use a steaming device, or use a device, a pot or container, which is not toppleable. But then almost all the containers we use can be toppled. So best idea is to keep it in a sink or a very stable position before you start steaming.
There was a question on aloe vera gel. Of course, I would recommend aloe vera gel in adults. We have done a trial at National Hospital Burn Center. We have encouraging results with superficial burns. There is a trial going on. So once the trial data is out, we'll have more information how to use aloe vera gel, commercially prepared ones, and what is the strength and all those things will be scientifically, we should be able to scientifically answer that question. Simply because we know that world data suggests aloe vera is an effective method of treating burns, but you have to understand we don't have those products. So the additives and commercial products have their different methods of preservation of this aloe vera. Unless that is proven on our skin, especially brown skin, we will not advocate unless it is proven by a clinical trial. That's a scientific method. So we have embarked on the one of the brands available. So we will give you the details in about another couple of months' time. We should be able to answer that question scientifically. But I would recommend if somebody is personally using in an adult, not in a kid, don't use it in a kid. We don't know the effect of the preservative products, because there's, even if it is 95% aloe vera, there's 5% preservatives. So we don't know how preservatives are going to work on superficial burns. I'm sure it's fine, but without clinical evidence of that particular product, I'm not going to say yes for that. I'm sorry at this point. Yes. We can move to the next.
And other unpractical point is, I have seen few cases where they have not scrubbed well and then applied collagen and went into trouble. So then they have tried to give another anesthesia and tried to remove that, and then they have made the burns worse. So scrubbing is very, very important to apply collagen.
So the technique of scrubbing is quite interesting, because I used to scrub it really scrub with a blade, and we are quite good at it. But now recently we have converted to the dressing scissors. Dressing scissor, when you open the jaws and use that sharp edge to scrape the burn, you should be able to get all the dead cells out and have some pinpoint bleeding and arrest the bleeding before you put collagen, because if you have bleeding spots and apply collagen on top of that, as it is as much as inviting infection onto the burn. And also what Selva said is quite true. If you apply burns on a deep burn or a burn which is which has not been debrided, not been scrubbed properly, you are inviting infection, and also the depth will increase, as well as if you try to remove it, then you are going to remove all the new epithelium also. It's going to make things worse for the patient. So never apply collagen on a mixed depth burn. Mixed depth burn, which means such as deep burns also, components also, without an expert evidence. So expert might decide it as a temporary dressing, but not as a maybe to keep the patient till the theater day, so to stabilize the patient and excise and graft the deep areas. But that is a choice of an expert, not it shouldn't be done by someone who is not an expert on excision and grafting.
Again, little point about, there was a question about nipple areolar complex. In the superficial burns, it's not immaterial, like you scrub down and do the same collagen dressing for the nipple areolar complex. But in deep burns, in little children, girl child, it's very important not to debride the nipple areola area. Even in a deep burn, if you are debriding for skin grafting, we will preserve the nipple areola area, because the nipple bud, the breast bud, which will grow into a breast, can be debrided easily by a debriding knife, and the girl will never develop a proper breast. So it's very important to preserve the breast bud in deeper burns. So that area, even in deep burns, you can just leave that area and debride the rest of the area when you are going for skin grafting. That's a very important point, managing the girl child.
Thank you, sir. So we'll move on to the next case. Case number 3. So 26-year-old male patient, suicidal attempt with kerosene oil burn. The burn surface area was around 40% and presented 6 hours after the incident. So these are the pictures, and I would like to ask Yasas sir to give his ideas regarding this patient's management. Over to you, sir.
Yeah, thank you, Sean. So it's very important to know that I think all of us know that there are no major accidental kerosene oil burns happening in Sri Lanka. Majority are suicidal, but there's a certain percentage, about 15-20%, which is homicidal. So, and these patients, when they present, they will, some of them will present telling what happened, but most of the time they will come as accidental bottle and propylene burns. And it's important that we know the diagnosis when they come, because that is very important to understand the patient's injuries and also understand the patient and the background. So if it is a suicidal kerosene oil burn, then we know the patient is depressed or stressed to the level that they have to commit some deliberate body harm. So they'll be very agitated or depressed patients who sometimes don't have the hope for living. So it's the job for us to get the patient motivated and treated with empathy, rather than giving sympathy to the patient, to get the patient to our side and help with the management. Said that this is a emergency situation, it's a big burn, 40% burn, and these patients should be given burn first aid, that is irrigation as soon as possible. As soon as the vitals are assessed to be safe, the patient should be irrigated to stop the latent heat causing the burn area and the depth to increase. And so after the first aid, the proper management of the burn, A, B, C, D, E, F, the airway, breathing, circulation, disability, environmental control, and full body assessment, fluids are very important to go in that systematic order, which is closer to ATLS, but it's not the same as ATLS, slightly different. And being a 40% burn in a suicidal kerosene burn, there's very high risk of inhalation injury. So this is a patient I am very worried about. The heated gas inhalation, that is the upper airway inhalation, as well as the lower airway inhalation injuries. The upper airway injuries, the problem is can last from 24 to 48 hours, where the respiratory mucosa can swell and obstruct the airway, upper airway. So we have to observe the patient for 24 to 48 hours, keep the head end elevated, give humidified oxygen, and check whether this patient can go into obstruction. The earliest sign of stridor, the patient should be intubated. We don't have the luxury of intubating all patients with facial burns, perioral burns, oral and facial hair singeing. The textbook explanation of inhalation injury, we don't have that luxury, because if we intubate a patient, you have to put the patient into the ICU. But the patient should be observed. The first observation of stridor, the patient should be intubated, and the facilities to intubate should be available. And what we are not very aware of is the second part of the inhalation injury, which is inhaling particulate material and the chemicals with kerosene burn, which can come as a bronchopneumonia pattern after about 5 to 7 days due to damage to the irritation of the alveolar airways. So to prevent that, we promote the patient to mobilize early chest physiotherapy. And for the first 5 days, we where our facilities are available, we nebulize the patients with 0.5 ml of heparin in 1.5 ml of normal saline, and 0.5 ml of N-acetylcysteine in 1.5 ml of normal saline, alternatively every 4 hours for 5 days. That will prevent the cast formation in the distal airways. So in addition, this is a major burn. The fluid management should be immaculate. But now we are moving more into dry burn management. That earlier we used the 4 into in the Parkland's formula. Now we manage them as 2 to 4. So with the clinical experience, we can go for the denominator as 2, 3, or 4, and then go by the urine output. And this is a large area of burn. The upper chest, there should be facial burns. And on the third photograph, we see burns in the abdomen. Hopefully the genitalia is preserved. And we'll go for early scrub down. And in this patient, we'll go for serial sulfadioxine dressings. The burns in the front appear deep to me. Probably the patient may have run after the burn. And so in this patient, we can't graft this whole patient at once. So we'll dress the patient for about 10 to 12 days, and then see whatever percentages which is healing by epithelialization. Then rest of the area, on a priority basis, we'll start skin grafting. And it's very important to give pain relief to this patient. This is extremely painful in large areas, and aseptic dressings. And if you can keep the patient on a isolated area is very good because they are very vulnerable to cross infection. Oshan.
Thank you, sir.
Yeah,
And
other point to address here is these burn dressing itself will take maybe 45 minutes to 1 hour for two people and two attendants helping, and maybe some nitrous oxide gas inhalation. So it's maybe difficult in a general surgical setup. It should be by a trained people.
thank you, sir.
And Oshan, one point, can I add one point?
Yes, sir.
And all these major burns should be referred to the psychiatry department. Even in accidental major burns, refer to psychiatry department and also to the nutrition unit to start the management from day one.
Yes, sir. Thank you, sir. And as you highlighted, sir, the importance of fluid management, assessing the burn correctly, and as you mentioned in your discussion, so we observe these patients with dressings for about 10 to 12 days, as you mentioned. So the burn after the burn scrub, and as you can see, most of the areas were epithelializing, and some of the areas, as you mentioned, appear to be deep in terms of in relation to the lower back area. So those area we grafted. Anything to add, answer?
Yeah, I think the surgeon has to make the call whether to go for excision, early excision and grafting, or early excision temporizing or grafting, or just managing with regard to superficial burn. So this was, I think, the whole area. We made the decision to manage it with dressings because we knew that this is going to heal, especially being two things. One being a male, because he has hair follicles and deep hair follicles, so epithelialization is much predictable, and also the nature of the burn, and I think he had and also the amount of resuscitation that he has got, as well as the age. So those few factors that we have considered and decided to just manage for 2 weeks. If anything that goes more not healing more than 2 weeks, we would generally graft them, because then the scarring is too bad. It's worse, and it's much worse than a skin graft. So skin grafts are much better, looks much better after excision and grafting if the burn is taking more than 2 weeks to heal. So because it at 2 weeks point is going into the chronic phase. Acute phase burns, we call it acute phase burn is over, it's going into the chronic phase. When the chronic phase burn is coming, then we know that it has to be grafted. Otherwise, the outcome is bad in terms of the scarring. So this, I think, this is one case that, of course, the dressings have to be done very aseptic techniques, and you have to take care not to damage the epithelialized surface. And if you are applying silver sulfur-diazine, I recommend having a thin layer of gauze and apply silver sulfur-diazine on that gauze and putting on the patient rather than applying with the hand, because it doesn't stay on the patient, and it'll create another pseudo esca. We call it a pseudo esca. If you can't get, we will be applying silver sulfur-diazine on top of another layer. So even if you, sometimes it's very difficult to wash these patients, because you should not bathe these patients unless they are infected, because they are 40% burns. So we generally advise not to use, not to bathe them, but actually to, I think, Oshan, your screen went off. Sorry. Oshan, are you there, Oshan? So till he joins, I will share this slide with you. So this gives how we are supposed to look after a bird. So this is what is known as. Can you hear me?
Yeah, we can.
So so this is important that airway, spine, breathing, oxygen, and circulation. This is called primary survey. If juniors are there, surgeons, I'm so sorry that we have to go down a little bit because I think there are some trainees as well. So the primary survey and secondary survey. Can you see the difference between ATLS protocol and the Burns protocol? We call this the SBEMC protocol. We can't call it EMSB because that is a trade. This is ownership. There's ownership. So, but can you see the in between? There is FATT, FAT, and also first aid is effective after 3 hours from board. That happens after the primary survey. You don't send a patient with a head injury to the water shower to get a cooling done. But if it is more than 3 hours, unless it's a chemical burn, we don't wash the patient unnecessarily because it can adapt to hypothermia and make the burns deep, and because of the ischemia of this zone, we can call it. This it has a depth. The zone of stasis is dying cells. It can be resurrected if you actually do the proper resuscitation plus good first aid. So take out the heat, absorbed heat with running water, minimum of 20 minutes, running water. If there's no running water, advise if the hand is burnt, you just rotate the hand inside the water bucket, so that also takes out. The principle is to dissipate the heat that is absorbed by the body. And chemical burns is a different story. We are not going to touch on chemical burns today. So this classification is also a little bit important. So there are severe burns and non-severe major burns. So major burns are so the major out of major burns, there are severe burns and non-severe major burns. Severe means more than 15% in a pediatric burn and more than 20% in an adult. It's a severe burn. So it doesn't matter where it is. If it is this percentage, it becomes a severe burn, because the principle there is severe burn equals a body reaction rather than it becomes a systemic illness rather than a superficial wound. But why we call major burns is that the organ that is involved is maybe 100% burn. If it is a nose, if the nose is burnt 100%, it's a major burn, because that particular organ, and it needs specialized care. So these are the important things that you need to know when we talk about classification of minor and major burns. The major burns are classified according to non-severe or severe burns. So still they are major burns. I think is Oshan back online?
Yes, sir, I'm back.
I'll stop share, then you can share your screen. Yeah. We can go on to the next one, I suppose. For 40% burns, remember you have to follow the protocol to the so then first 24 hours fluid management, and next 24 hours onward you have to manage fluid resuscitation according to the assessment. So initial, somebody is asking initial fluid management. So there's nothing called a normal requirement. This is for resuscitation. So resuscitation is resuscitation. There's so it becomes there's nothing called normal. If it is insensible loss you are talking about, it will be added from the next day onward. Resuscitation is different. But in kids we do we give maintenance fluid, which is given as dextrosaline. Plus we will add some potassium requirement as well, and that is given through a separate line. So one line gives the resuscitation fluid, other line gives the maintenance fluid. So this is very clear, and the formulas are there. We will share it with you If you go to a website called slapgrass.com, I will share the website details as well as the Facebook page that gives you also information. So you can just go there and get these details straight away. Oshan, shall we move on?
Yes, sir. Thank you, sir. So the last case, 31-year-old male patient who had trapped inside his workplace where he was making firecrackers, and it was a trapped type of burn injury. So this patient presented after 4 hours, and the burn surface area is more than 90%. And I would like to know our expert panel's opinion regarding this patient's management. So, Selva Ganesh, can you comment on this patient?
As this is 90% burn, and then there is a possibility of inhalation because he got trapped in the during the incident, and most of the back areas looks deeper. The whitish areas, most of the time they are going to be full thickness. So the death chance of death is very high in this patient because of inhalation and the higher percentage with the full thickness burn. So we had to go according to the same resuscitation protocol, and if necessary we may have to intubate at the beginning if the airway is compromised, and then the A, B, C, D, E, and then at the stage of FATT, then we have to go for the fluid management. So this patient will have lines like large canal or central line, most probably, and then the catheter, NG tube, and then after initial fluid resuscitation, and when we are happy with the urine output, then we have to think about the dressing, which one we are going to apply. Most of the time, when the cost effectiveness is considered, this silver dressing in this patient is effective, but it's going to cost a lot, and the survival rate is also not going to be very less. So then we have to explain at this point to the relations. So main objective is to release her pain and keep her pain free, and in the meantime doing her management. So as this patient is 31 years, we can try maximum to get the wounds healed, because the anterior aspect looks superficial or mid-dermal to superficial. So there is a those areas, the anterior aspect, abdomen and neck, and the upper arm, if they heals with our dressing, then we can get the posterior surface aspect grafted with time. So initially, these patients needs HTU care, most probably, or maybe the ICU care with the ventilation, and then the one-to-one nursing care with the burn team involvement, and then the fluid management, and then the nutritional management with vitamins and minerals, and then physiotherapy, and to mobilize and the chest physio plus all the limb physio. And after managing for first 2 days, so after 48 hours, she may need colloids and albumin, because all the nutrition cannot be given in this patient with the NG feeding. So when we manage this patient with all the aspects I mentioned here, then there is a chance of survival. Maybe I can say around 20 to 30% chance he has. So a very high chance of losing this patient because of infection, pneumonia, and the ARDS, and then the skin wound infection. Especially when compared to trauma patients, these burn patients are immunosuppressed. So when we get the trauma patient, we don't see them as immunocompromised patients. But these people are immunocompromised and they go into sepsis soon. So sometimes we may not get the ideal setup or ideal isolation facilities with the burn ICU. So in our ICU itself can give infection to these patients. So that's a major worry for me because our ICU sending these patients to our ICUs itself, they will give some complementary infections.
Yeah, I think this, as Selva said, if it is a little bit less, we would go all out for this patient. If it is up to 70%, I would try in my setting because I know with experience that in our unit we can only salvage up to 70%. That is our target is actually 70% salvaging 50% of 70% burns is our target at the that is called our T50 or SD50. So that is our that's our 50% mark. So 50% of 70% burns saved means that is a big achievement for our unit. So definitely, because we have actually intubated this guy thinking because he was sent as 60%, and then when we did the proper scrub, it came as 94%. So in our setup, it's going to cost a huge amount, and infection and everything if we start debriding. So it's basically tender loving care for this patient, and pain free, and probably he will not make it through 48 hours in my experience. Even if he's 31. Of course, having said that, I had 90% burn surviving up to more than 1 week. So he was burnt up to the neck. So his face was, he didn't have a facial burn, single facial burn. I don't know how he did it, but he was walking around for 7 days. He died with a catastrophic gastric bleed. So we couldn't do anything because we were only doing dressings for him. But he could walk around, and he was pain free because the whole thing is full thickness, and he was not having in pain that much of pain also. So the other aspect is what we'll do is we'll get Jas's opinion also. Then I will talk about sort of a salvageable level burn. Is that all right, Oshan, for a few minutes? And what we currently do, how we change our practice at the burn center. We will talk about that a little later, and then we can take some questions. Yes, do you mind?
Yes, sir.
Yeah. Thanks. Now, with this patient, 90% burn, even in a 31-year-old, with entrapment, that is a definite inhalation injury, and deep burn because it's a firecracker factory burn. It means there's a lot of deep burns, inhalation injury, and that is at in Sri Lanka, I think this is non-salvageable. So then there's the option if the patient is performance state is all right, the patient is conscious, then we can give the pain relief. But if he wants to communicate with the family, we can allow that without intubating him if the possibility is there. And also it's the time to get any information, medical legal information, the police interviews, anything, because we know this patient is not going to make it to the first day. And so that part of tender loving care and communication of this message to the relatives also in an appropriate way is also very important.
Okay, sir. Thank you very much for your input.
Yeah,
And intubating this patient is a bit of a tricky decision because as this patient is 31 years and entrapped and difficulty in breathing and we can't be just watching them breathing and having difficulty. But when we intubate, our burn wounds does bad because when we intubate with the positive pressure, then the IVC pressure goes up and then the leak is more and third space loss more and the burn wounds itself become worse. So if that so the intubation itself is going to do our wounds bad.
Yeah, I agree. So the 60% burn, now the protocol we follow is we would intubate only if we are going for a scrub and we decide to salvage this patient, because scrub will need at least ketamine or something. And if we think as inhalational injury, patient is going to go into obstruction and the patient needs a bronchoalveolar lavage, we not frequently do it, but we do it with the help of respiratory physicians. If we go for we usually diagnose it with bronchoscopy now, because we have bronchoscopes. We will diagnose the inhalational injury, then we take some samples and also do the bronchoalveolar lavage to get rid of the soot, so it won't cause the chemical pneumonitis, and will reduce the risk of infection. The soot induce the chemical pneumonitis. So that is one thing that we do in occasional cases. Of course, this one was in the shock, and he was getting swollen. So, and being the initial assessment was 60% by the local hospital, and they have transferred even without a proper line, and also transferred without anyone accompanying the patient or not informed. And suddenly we got 3 patients similar to this one, 100%, 160% according to them, this one, and this one according to 70%, another 65% burn. So we had 3 patients coming at our doorstep at once without any warning. So if there are people who have transferring a 90% burn, just give a call and see whether we can salvage the patient. If not, the problem of transferring the patient's relatives have to take the body. Taking a body is very expensive. And if you talk to the funeral parlors, it will cost about 1 lakh or 2 lakhs even to go from here to Negombo. So transferring a dead body is quite expensive for these relatives, sometimes the relatives. So the body is in the morgue most of the time, and the relatives will not even be able to take the body. The other issue is if you're not going to do anything and if you are still being pressurized to transfer, take a call. We would take even a video call and explain to the relatives, and it's a danger of transferring a patient with the inhalational burn. So we will tell them that we will advise, we will manage the patient there, and once the patient is stable, only we will take the patient to our hospital, which doesn't happen most of the time. Most of the time, the patient passes away in the middle of the night or in the next day. So if the patient survives 48 hours, then of course we will talk to them, and usually the relatives have calmed down by that time. They tend to accept the fate, and this is one way of preventing unnecessary verbal arguments and unnecessary arguments. If the relatives don't want you to transfer the patient, just give a call and talk to us or the plastic surgeon, whether the plastic surgeon is going to do actively salvage this patient. So this inhalational injury, of course, I told about the bronchoalveolar lavage, and then we do the scrub, and then we actually do decide on what to do. Now, because we have a skin bank now, at the moment we don't have skin, but because the skin harvesting process is very slow, we don't have that much of cadaveric skin. So the cadaveric skin is going to become the major player in the future in Sri Lankan burn scenario. hopefully it will catch up and it will save a lot of lives. And once the cadaveric skin is available at the skin bank, we will be able to excise and put cadaveric skin. As Selva said, these burns are immunocompromised. So that is the reason that we can put cadaveric skin to take. So cadaveric skin will be there for 4 to 5 days, and we will, sometimes less than a week, we have to remove it and start grafting part by part or replacing the cadaveric skin again on live tissue. So we excise the burn and put cadaveric skin. So we have started the process, and now it's actually doing very well. And of course, there are ways to expand skin where there's mesh skin, and also meek skin graft, and also the newer techniques are coming up, which is called BTM. It's going to come to Sri Lanka probably very sooner than we think. It's very expensive, but we can go up to maybe up to 70% burns. We will be able to save more than 50% of 70% burns if that comes into Sri Lanka, but it's going to be extremely expensive. But if the company is willing to give it a reasonable price, we should be able to increase the burn survival. So I think Dr. Satish Vijayman is online. Are you still with us, Satish? He is actually in UK practicing plastic surgeon, practicing in UK now, and he's attached to a burn center in UK. Is Satish with us? Maybe he has. It's during the daytime. He's still busy with work. So that's so. These are the new developments that we are currently improving. So trying to improve. There's a skin bank, and of course now, not like earlier.
And sorry, Satish Vijayman is still on line. He's with us.
He's tuned, but he's not. Maybe he has just gone out while the phone is on. We'll try to message him and try to get him also involved. And so any questions, Oshan, on this one from us? For us, sorry.
No, sir. So I put this case for the discussion because it's a difficult decision that we have to take in terms of considering our infrastructure and our expertise and the things that are available with us. Whether we can do some salvage things, but depending on the factors that the panelists have discussed. So explaining the patients and the relatives regarding the condition is important. And I think in other countries, the threshold for salvaging these burns might be higher depending on their expertise and the things that available for them to get the skin cover. So shall we move on to the questions? There are some questions in the chat.
I think questions asked. Some of them we have actually answered while we went through the slides. So there's an open technique of dressing. So pseudosulfadiazine, what is your practice, Yasas? Do you recommend just applying pseudosulfadiazine on the burn and just covering it, or would you apply on a gauze and wrap the patient with gauze attached with SSD? Because I have difficulty in convincing my nursing staff to change their practice, apply pseudosulfadiazine and all wounds. They love it, but the patients also love it because it's very cool to apply on a burn. What would you do as would you still practice, or are you any new things that you have come up with? Selva, both of you.
The silver sulfadiazine, I go for if I feel it's going to be infected, and then I can't go for other dressings. Especially I don't apply if it is infected. I don't apply silver. So if I have any suspicion of infection or late presenters, will have daily SSD. I just apply a bit thicker layer of SSD and have daily wash and then daily change it. So that gives good results with regard to suspicious case of infected burns or already infected burns. Otherwise, I don't.
Yes.
Again, if I'm applying silver sulfur I will always cover. I will use a thick layer of silver sulfur acid and use several layers of gauze, and even use almost always use cotton crepe bandage dressing. And but if any burn, I'm not happy to use silver sulfur acid. Let's say early features of infection, or maybe after day 7 to day 10, then I will change the dressings to a mixture of povidone and paraffin oil mixture. That mixture initially we cover, but later on we just apply the povidone paraffin dressing and put the povidone paraffin on the burn, but keep it open.
All right.
But
So that means,
SSD I always cover.
Yeah, so we also we now we don't use the povidone. We have nearly stopped povidone because with the paraffin, yes, on the faces, but now faces we are managing more with the collagen dressing. So the povidone ointment is mainly for perineum now. So perineal area most of the time. So the rest of the areas, we feel that we should go for the other dressings because povidone, because the colonization rate is pseudomonas, so it's very ineffective against pseudomonas. And if you have think that if you have infected burns, so what are the antiseptic things that you can use on these to clear out a certain amount of colonization? Because now we graft them. Now we go up to nearly 40%. We will graft at least part of the burn on the first attempt. So we will excise and mesh graft most of the cases, and we are getting some good results with it because we have cut down the waiting time for skin graft. We don't wait till the burns list comes. We would take a theater and graft, like what we have been doing in Kurunegala and Gaul. We don't wait till the burns day comes on Thursday, Friday, Saturday. Other days also we take the patient in and graft. We don't wait around now. We graft part by part. So sometimes we have gone up to 30% cover with meshing skin mesh. So then they are actually doing well. Although because now if they're deep, there's if we cut it, we have to graft it. So that's the main thing that we practice now. Yeah, and antiseptics. What's your opinion on antiseptics?
Again, we used to use the commonest perpetrator is Pseudomonas. So we used to use rotation antiseptics using mainly acetic acid, but we will not do overnight dressing with acetic acid. It's acetic acid touching and then washing it off. Because one thing is it's the absorbance of acetic acid in large areas, and when we applied acetic acid overnight, we observed maceration also. Same with Milton. So Milton is not in my rotation. So it's acetic acid touching, alternate povidone and hypertonic saline, and sometimes SSD. But lately, I have moved using PHMB dressings, Prontosan dressings also with some good results.
Yeah, so same here with us also. I've used Aquacin because that is buffered sodium hypochlorite. So that is actually doing wonders with some of the donor site infections, and as well as clearing out a lot of bugs. But I get your idea of biotin because I think biotin containing liquids are coming into the market. One is Prontosan, and there is a Sri Lankan product is also coming up very soon. So it's biotin. Those who are listening to us, biotin is something that is working against biofilms. So this new technology of it's like a soapy material where once you apply it, the biofilm gets disturbed. and then you then you attack with this other antiseptic solutions. The soapy solution will disturb the biofilm, and then biotin will attack the bacteria. So that's the latest that we have started. We are going to start a trial on. We have actually done few cases, the index cases, and we are happy with infection prevention of superficial burns with biotin containing these products and some of the products, and also the infections following grafts, and also donor site infections. These are some of the things have been very effective, and we are using it as a rotational. Sometimes we rotate it with Aquacin and Frontosan. The mainstay is for Pseudomonas in Birmingham, because we've learned it in a few years ago, is alcohol, the isopropyl alcohol. If we take the patient into theater, we either use, we don't have cetrimide. Cetrimide is the one that is used in Australia, but we use hibitane or the chlorhexidine scrub, and then we used to wrap the patient with alcohol soak goes for 15 minutes. So that actually they have proven that they can eradicate Pseudomonas colonization by alcohol containing alcohol wiping. They call it alcohol wipes. So except the face, they will wipe out whole the body with alcohol after they shave every inch of hair from the body, including hair. Everything we have to shave off, because they are the sources of colonization in these patients. And also, once you shave, you can't have a conscious patient when you apply alcohol, because it's bloody painful. So, but we will always general anesthesia, tell the anesthetist to give some good analgesics before we apply the alcohol padding on the patient. So we think that we have got some control over the Pseudomonas at this particular point. Even the donor sites are clean with those things. So then this basically we are trying to decolonize the patient and then trying to seal off everything. And new development is that now we started doing applying some negative pressure therapy on isolated body parts with if we feel that it's infected, and we debride it first, and if you are not happy to graft it, we will put a negative pressure and then wait for about 4-5 days before we graft. So that's one. Even if the whole limb, lower limb, we try to put negative pressure with several things, so that we get a good vascularized bed to graft if the patient is either unstable due to various reasons, or if we run out of skin grafts, and we use this as also. So these are new things, new developments that has happened, and hoping that this is not for you to try out, but this is show that we are trying out our best, and we are improving day by day, and to people to love, start taking burns seriously. And we need a lot of plastic surgeons to take up burns as a serious business and serious work, serious work, because you have to, unless you like burns, you will never do good burn work. If you like treating, because these are very because we have not developed other areas. You say lab quality, we are at world best. Our surgeons are probably doing the same quality as any other country. But when it comes to burns, we are actually still far behind of certain countries. So we are trying to improve on it, because we need more people handling burns. Because if we get inundated a lot of burns, one person, we will not be able to develop the field. Hopefully, we will inspire some of the younger generation to take us into the next level. We will create as much as opportunities for you guys to train in the future. Anything to add before we wind up today?
Yeah, burn itself is a big burden because the dressing itself is a burden, and then they need individual care, they need individual physiotherapy, they need individual nutrition, then they need counseling. So it's a big burden. So we can sometimes we have even we may have to keep on a surgical ward with the next patient is a diabetic ulcer. So I think we have to have more and more trainees and then the burn centers, maybe regional.
That's a good move, Selva. If you can send a letter through the direct hospital director to establish a burns unit at because I suggested this earlier to Lieutenant Director also to establish a burns center as a not a center because center means the word center. We are also trying to establish a center. Although we call it center, it's not really a center. There's a definition for it. Either a burn facility. Most of the areas are now actually most of the plastic surgeons are maintaining burns facilities. So we have to upgrade that to burns units, and then trying to establish regional burn centers. As once you get a burns unit going, we can actually. So somebody has asked about last question. Asked about analgesics in burn, pediatric burns and adult burns. I think if it is a severe burn, always IV morphine, because the patient will always be pain-free when if you give the correct amount and you are not going to cause a patient who is in pain and severe agony, they will never go into respiratory arrest. Don't worry about it. So the patient will be extremely in pain, and then once you start giving, they will lose the pain, and then once the pain is over, you stop it. So then you give little by little that the volume calculated, the dose calculated, IV. So that is most important thing that with regard to burn pain management. You can add oral morphine, and taking the dressing down is the most painful thing. Not really the dressing. Removing the dressing is the most painful thing. So you have to give pain relief half an hour before dressing changes. Remember that. Now we have instructed the doctors to time everything before in our unit. Before taking down the dressing, they have to give the analgesic dose or oral morphine and also suppositories, diazepam and everything. We give them as a cocktail, and then also in the theater we will give a half dose of ketamine and also add some fentanyl if that is also small dose of fentanyl also if that is also not enough. So burn dressing is a very difficult business. Don't give general anesthesia because the general anesthesia you don't need it most of the dressing changes, but you need to give adequate analgesia. So the ketamine is a wonderful thing that we are still using it. Hopefully it will be there for another 30-40 years if there's nothing comes similar to that. Yes, sir?
Yeah, and that one parting point, we discussed that when the burn is not healing after 2 weeks, that is, it goes into the healing by secondary intention, healing by scarring area. So we know if we dress a burn for adequate time, maybe 1 month, 2 months, or 3 months, all burns will heal by secondary intention. So the skin cover will be obtained. But however, the important thing in burn management is to follow seeing your patients for a long time. So if you follow the patients adequate to long enough, maybe 1 year or 2 years, you will see that by 4 to 6 months, contractures developing. So the idea of doing the proper burn management and timed skin grafting in areas which are going into secondary intention healing is important to prevent the burn contractures, which can be very difficult to manage after a long time. So if if at any level, if you are following your burn patients for at least 1 year, 1.5 years, then you will always see how what are the changes, whether they are responding, are they contracting. Then you can change your protocol, the way you manage, or you can manage the do the preventive management for these complications of burns. So burns is a disease with a prolonged, it's a life-changing thing, and with early good management, I think we can change the lives of these patients.
Thank you, Asas. I think I would like to thank two individuals who have actually done a lot of work in establishing the skin donation program. One of our two previous, now they're actually in overseas training, Dr. Randil D. Alvis and also Dr. Jeevan Rankot Kumbura. Those two have actually pioneered and helped us to establish the skin donation program in Sri Lanka, and they have helped us to streamline the process. And I would like to thank them because they have done something that's going to change a lot of lives in the country, and hopefully we'll be able to save more and more lives with cadaveric skin in the future. With that note, Oshan, I would like to thank Oshan because if he starts thanking everybody like the moderator, he will not be able to get our usual appreciation. Thank you, Oshan, for compiling this wonderful case series. And I will expect everybody to upload, but of course, I'm not sure whether everybody sees you, but yes, but really good case selection and generated a lot of enthusiasm. And thank you so much for joining today. And thank you, Dr. Nias is still there. Thank you very much
Can you give me 1 minute, Gayan? I just want to bring your point and Selva Ganesh's point as well. That is, we all should try very hard to establish at least provincial burns facility or burns unit or whatever we call it. I think we as a college should try and write to the ministry and ministers and whatever, and even to the president, and to establish it, because I have worked in many areas during my sort of long betting lineup, and I found all your cases sort of brought me my memories back into the scene, and how badly that we managed and how well that we could have done. And I had a ward where colostomy patient was there by the side of the burn patient. That's how it was. And underneath the bed, there was another patient. So we all have gone through this mill. So I'll take this opportunity to thank everyone, including the 3 resource persons, and yes, as you correctly said, moderator, and the SLSE organizers, Sandani and Kalana Palyaguru. And in the meantime, I would expect for this resource person team and everybody to try hard, and we will do our best at least to sort of bring this to the health ministry, the importance of having regional centers to manage certain extent. If that is the case, then all these transfers that you got in one day can be minimized, and so we will try hard. I expect everybody's cooperation. Thank you very much. Thank you indeed for everybody. Wonderful job today. Thank you.
Thank you, Sandani, for doing the organizing part. Thank you.
Thank you very much, and we are going to have this JHEAD discussion every month. So next one is going to be on breast cancer, which will happen on 8th March. We expect all of you to be there as well. And thank you very much again, everyone.
Thank you.
Thank you.